And there we go. Great. So hello again, Dean Bugai, Office of Main Care Services. We are here today, gathered this afternoon, to discuss a little bit about our Section 11-teen SUD Substance Use Disorder Care Initiative waiver that we have gone through with CMS. And before we really get going and dive into some of the details, I wanted to maybe give our Office Director, Michelle Probert, the opportunity to say a couple words.
Great, thanks, Dean. Good afternoon, everybody. My name is Michelle Probert. I am the Director for Main Care, and sorry, I can't change my name. Sometimes I feel like I am Main Care Services and it defines my life, but that's not actually my name, despite what it says on Zoom. Thanks for taking time out of your busy and important work this afternoon to join us. This is not about me, but I will share that this feels especially exciting because my first week in this position as Main Care Director, we had a public hearing for our plans for this 11-15 IMD exclusion waiver. And so it's really exciting now, over 2 years later, to see things coming to fruition. And I think also within at least my first month at Main Care, I heard feedback from some of our SUD treatment providers, residential treatment providers, that you were really looking for the opportunity to be able to expand capacity. And so it's great to be on that path. We are all well aware that we are still in an opioid use epidemic, and things have only gotten more dire with the pandemic, and that's true about substance use disorder in general. And so the services you provide just are even more critical than they were, and we're hoping that that this project, as well as other plans we have in store, will really help shore up capacity in the system as a whole. And in addition to just the question of capacity, we're also very excited about the opportunity that that this demonstration project gives us in terms of solidifying our plan for substance use disorder treatment more broadly from a community-based perspective. And with that, I didn't give him a warning, but I would also like to see if Gordon Smith would like to say a few words to the group.
Well, I'm never without words, Director Probert. I just want to thank you all for being interested and participating in this session. I do think that one of the real, I generally talk about 3 really significant deficits in the state, and one is residential care, and one is detox, and the other is adolescent care. And so while I'm very proud of what we've accomplished in 2 years, we've got a lot more MAT treatment available. We've got 70,000 people in the main care expansion population, got more recovery residences. We've gone from 7 to 15 syringe exchanges. We're very proud of what we've done, but we've not been successful in keeping people alive to get to treatment. And every week I am talking to parents, of friends, of family members, trying to get a person that's been using IV drugs for 10 years, and even intensive outpatient is not going to be enough for them. And they're just, every patient that's sent from Project Hope to New Hampshire and Massachusetts, to me, is a failure, an abject failure. So this waiver is actually the best opportunity we've seen in 2 years to actually get some more beds. And I've talked to many of you about it, and it is a high priority of the Mills administration. So thanks for your interest, and we'll do anything we can to help you add capacity. Thank you, Michelle.
Thank you, Michelle and Gordon. So I think I'm going to get started. I'm going to attempt to share my screen here. So you should be seeing it pop up in just a moment. So you should be looking at a slide deck now. We'll run through a little bit of slides, and I'll break on a discussion here. So In November of 2019, we went and put in
Dean,
a, yes.
I'm sorry, I'm totally cutting you off, but I saw that Jessica Pollard just was able to join us as well. And so I just wanted to give her the opportunity to say hello also, and then I'll stop interrupting your flow. Sorry.
Sounds good.
I feel like I'm always interrupting Dean, so he probably is used to it by now. And apologies for joining late. I think I know most, if not all of you. I'm Jessica Pollard. I direct the Office of Behavioral Health and absolutely want to support the expansion of the residential programs under the waiver, but let's let Dean talk about it and then I can chime in if I have anything useful to add.
Excellent. And so as we are going through, if anyone has any questions, try to direct them through the chat, and then I'll be also stopping at spots so we can, have some discussion, but we're going to have some folks helping out through the chat for managing questions. So appreciate that. And again, thanks so much for your time. So back in November 2019, the department submitted a waiver application to the Centers for Medicare and Medicaid Services to seek an opportunity of an 1115 waiver. And what this 1115 waiver in part does is it allows us to waive what is the IMD exclusion. And so the IMD exclusion, in case you aren't aware, is it was enacted in 1965. And what it did is that it made it so that the federal government would not allow states to leverage federal monies for inpatient psychiatric care for really individuals, all the way up through to age 65, although some exemptions were made for folks under 21 years of age, called the Psych Under 21 benefit. So we're really talking about 21 to 64 is where the exclusion kind of predominantly lies, though. So an IMD in and of itself is a hospital, nursing facility, any other residential type program institution that is above 16 beds, and then primarily engage in the providing diagnosis, treatment, or care of persons with mental illness, of which substance use disorders kind of fall under. So, for looking at the facilities, what is an IMD? So currently in our service delivery system, a PNMI Appendix B SUD residential program with 15 beds, not an IMD. But if you take that same program and increase it to 20, it would be considered an IMD, because it's really that 16 bed marker. Now, looking at medically supervised withdrawal units of acute care hospitals, that's up to 200 beds. That's not an IMD. So what's the difference? How does this work? There's the way IMDs are classified is based on sort of their standalone sort of units. And so if it's part of a larger kind of hospital medical care system, of which some of our medically monitored withdrawal programs are kind of incorporated into other umbrellas, they would not be considered an IMD, whereas if you're a standalone hospital, it would be. So that's how we see our state-owned psychiatric hospitals, or Dorothea Dix, those would be considered IMDs. The psychiatric residential treatment facility, that is a unit that is for youth under the age of 21, so that falls under that Psych Under 21 benefit, similarly to Spring Harbor and Acadia. So as I said, we applied for the 1115 waiver in 2019, but the waiver opportunity became available in November of 2017, when CMS put forth this opportunity as a new way for states to address substance use disorders and to increase access to care, and also make some other more substantive changes to their delivery system to support access to substance use treatment. And so an 1115 waiver in itself is a waiver that CMS, it gives the Health and Human Services the authority to waive certain provisions of Medicaid law to then give the states the flexibility to improve our programs. It can improve experimental pilots, demonstration projects to help promote the broader goals of Medicaid and CHIP. So far, for the 1115 SUD waivers, there have been 29 states that have had them approved thus far. And so the ones in green are the ones that have approvals. So thinking about mains demonstration, again, we put it into 2019, and we look to pair an expansion of access to facility-based care with some other larger system reform and the creation of pilot programs to help close some gaps in Maine's SUD system of care. So we received approval from CMS in December of 2020. The approval does not necessarily mean that we can operationalize it yet. We'll get into that in a little bit, but it is absolutely the first step and a great step that we're very proud of that we've been able to achieve thus far. The pilot programs that we're looking to do, they are still under CMS review. We actively work with them and talk with them on a weekly basis through all the various components of our waiver. Some of the things that we're looking to do under our pilots were to develop some home-based skills development pilots. And so looking at some parent supporting programs, including the attachment and biobehavioral catch-up and visit coaching. Attachment biobehavioral catch-up is a program that is focused on parents and attachment. So looking at especially new parents that may have had SUD as a risk factor and teaching them proper and good ways to really engage with their child to promote proper attachment, decrease any potential frightening behaviors from the caregiver standpoint, promote proper nurturance, things like that. And then the visit coaching pilot is one that is a specific model around essentially the families that have been child welfare involved and that the children have been removed from the home. It's a model to better integrate and get the families back into stronger attachment through that process. We've also been looking at structured recovery housing and then looking at an eligibility expansion for parents working toward reunification. So just a brief overview of our SUD care delivery system, and this is all main care reimbursed programs looking at care coordination, including target case management, opioid health homes, behavioral health homes can be, another program as well. Outpatient services, early intervention services, experts, comprehensive assessment, outpatient therapy, intensive outpatient therapy, medication management, MAT, and then our residential services, which we're talking about today, which are, our halfway house services, extended care, rehab type 1 and 2, adolescent residential rehabs, and then the non-hospital medically managed withdrawal programs. So as we work with CMS through our 1115 waiver, there are a number of components and requirements that the state has to do in order to meet our obligations federally for implementing the waiver. And so the first step is to execute an implementation plan. And so CMS wants to know how the state is going to respond to certain goals and milestones, which we'll talk about in a minute. And our implementation plan is sort of our plan on how we're going to tackle those with timelines, things like that. So one thing to be aware of is that I mentioned earlier, that while we have the waiver approval, we're not yet ready to be able to get federal funds for things. And that's because CMS needs to approve our implementation plan first. So that's the final step before we can start to get FFP for and any of the services for providers who wish to expand. We've submitted our plan. We have been working with CMS through some rounds of feedback, and so we do hopefully anticipate approval within the next month. That's what we're hoping for. So So the first step is the implementation plan. Then we have quarterly reporting on and monitoring metrics. We do have an independent evaluation. And so we have Pacific Health Policy Group, who's our independent evaluator, who's working with us to conduct that evaluation. There's a midpoint assessment, budget expenditure reporting, and then looking at changes to our system as well. So our goals and milestones that I've been discussing, they are set by CMS, and every state must submit the plan on how it's going to be addressed. So the demonstration goals, are looking to increase rates of identification, initiation, engagement, and treatment, increasing adherence and retention and treatment, especially looking at community settings, reducing overdose deaths, especially in opioids, reducing utilization of EDs. That's another big one. Reducing readmissions to the same level of care or higher, and preventing readmission. And then improving access to care for physical health conditions among beneficiaries. The milestones that we need to look at are, looking at access to critical levels of care for OUD and other substance use disorders, widespread use of evidence-based SUD-specific placement criteria. So for us, it's really looking at the ASAM criteria and making sure that our rules and regulations and policies really support the use of ASAM. And then use of nationally recognized evidence-based program standards. Looking at sufficient provider capacity at each level of care, including MAT, implementation of comprehensive treatment and prevention strategies to address opioid misuse, and then looking to improve care coordination and transitions between levels of care. So lots of stuff to keep us busy over the next 5 years. Some of the highlights from our implementation plan is we do have a number of initiatives that are currently in progress. So for those of you who have been involved with our Support for Me grant, looking at service locator tool and using open beds to work on that development, which we're very excited about. And again, looking at provider capacity, access to care, care integration and assessments. Also, along with our Support for Me, we are looking at lots of gaps and opportunities within our delivery system and thinking about how we might be able to address some of those to increase access to care. Also, through our Support for Me, we have funded a rate study for our Appendix B providers, which a number of you have been a part of. We're very thankful for and appreciative of your time associated with that. I know it takes a lot of time out of your day, but it also really helps us to be able to set appropriate rates for the services, especially because they haven't been addressed in quite a while. And then, as I mentioned before, requiring the ASAM placement criteria, we are actively engaged in work on that, and that also is a part of our implementation plan. And then looking at improve prescription drug monitoring plan functionality. Some of the things that we've planned thus far, looking at key pros assistance, in appropriateness of care assessments, so engaging them in some of that process, looking to close quality assurance gaps and creating more integrated residential provider and oversight process, strengthening requirements and incentives for Appendix B providers to facilitate access to MAT, adding ASAM placement criteria expectation to OHH, and then to use the Support for Me learning community to educate providers on ASAM as well. Medicare and our policy unit and in our value-based purchasing team is also doing a number of work, in this area and the SUD area more broadly in terms of clarifying our coverage, is looking at reducing stigmatizing language, assessing ways we can improve access to SUD, supporting transitions of care, and exploring incentive opportunities and quality metrics to improve outcomes across our continuum. So to operationalize the demonstration, we are still waiting for a decision on our pilots from CMS. We've gone through a number of back and forths and questions. CMS is very interested in our pilots. And one of the things that they really look for is how they can kind of cleanly map over to broader Medicaid authority. Like, can these pilots be coverable under Medicaid? And so there's a lot of questions and things that we're are working through with them to help them understand so they can map back. So we're still working towards approval there, and if those are approved, then we'll have further instructions to follow. And then for our demonstration under the IMD exclusion portion, um, we are configuring our systems to really look at having a new IMD specialty under our residential services provider type 55. So we're looking at creating, let's see, most of the specialties right now is sort of that 001 addiction services. I'm not sure if you guys are aware of how we code things or not internally, but that's how most of the Appendix B providers are kind of enrolled with us now. So we're looking to create a new specialty, and part of the reasoning behind that is that as we mentioned previously, there is some need to do financial reporting, things like that, and so we need to be able to know sort of who are those that are the providers that expanded and who are the ones that aren't, and being able to kind of separate that, and so the specialty through enrollment is the way that we're going to be able to determine that. And so providers must be enrolled as Medicare providers with this provider type. And then currently enrolled providers will need to do an update through their enrollment through a maintenance case in Health Pass. And we'll have some folks talk about that process in a moment. And the providers will also need to update their license with DLC. And I believe we have some licensing folks to talk about that in a moment as well. I think the first step for any provider who's interested, though, is to look at the updating your SUD license, because we're going to require the updated license for the enrollment portion. Any questions or anything that I've kind of gone through thus far? I know I've put a lot of information out there, so just want to give a moment in case anyone has any questions.
And there are no questions in the chat, Dean. You're all set in the chat.
Perfect. All right. Well, moving right along. So is Aaron Fodder on? He's going to try to make it. Doesn't look like he is. That's okay. So thinking about your enrollment and submitting your enrollment to main care. If anyone knows enrollment better than me, feel free to jump in, but I'll do my best to go by the slides. So submitting enrollment, you will go into Health Pass, the online portal. You can do an enrollment in your maintenance case through there. There are user guides available, and you can also contact provider relations and provider services through that number. So if you're looking to add the new specialty to main care, the 1115 waiver, as I mentioned, requires that we add the new specialty. You'll terminate your current specialty, ensure your license is updated, and then submit your maintenance case through the system. And so licensing, Heather Hyatt, I think I saw your name. I'll have you chat for a moment.
Thanks, Dean. Hi, everyone. Our slide's pretty brief with licensing. So really the requirement that we'd be looking at for any expansion of services or capacity would be to submit a change form application, and that can be found on our website, which is linked right here in this slide. The licensing part of the inspection for increased capacity or change of services is pretty brief and pretty quick. For residential sites for increased capacity, we're at the mercy of the state fire marshal's office because they also have to approve those sites for change of capacities. So they work on their own schedule. They are sometimes the piece that holds things up, although I can say they're great to work with, and they do recognize some of the urgency for us in getting some of these residential sites approved and capacity increases approved. So and that's pretty much it for the licensing piece. For if there's providers who are looking to add new services, then we would just need at licensing a program description, eligibility criteria, and we'd want to do a quick review of that before approving that application. And I think Dean's flipping to the next slide, which probably has our contact information on it as well.
It does.
Sorry, I have a question, both on the enrollment front and the DLC front. Can providers do this now? Do they have to wait? Like, what does the timing look like? If someone knows they want to expand beds, can they get in touch with DLC now? I know that our website for MIMS, I don't think the specialty is available yet. So could you just talk about the timing there a little bit for folks?
They certainly can reach out to DLC now. I mean, I think the real key is if there's any construction involved in that increase of capacity, the construction would need to be at least started, if not completed, for the state fire marshal to inspect and approve. But those are conversations that we're happy to have with providers and kind of do some networking with the fire marshal's office to get specifics and kind of handle these on a case-by-case basis.
And Dean, could you talk about timing a little bit on the main care side too?
Yeah, so talking a little bit on the main care side, we are working with our partners over at Gainwell to get all the system edits and everything into place. I think we're hopeful to target summertime to have this up and ready, which I think should jive pretty closely with the CMS approval of the implementation plan. We don't have a specific date as of yet for either of these, but and as soon as we do, we'll absolutely make them available to everyone. And then certainly we can, pull folks together to have another conversation if we need to, or just, go directly through the provider relations team. But I think summertime is when we're hopeful to have this, have the system edits done, have the implementation plan approved, and then be ready to support providers expanding their services who are interested. So with that, I think that really concludes our slides and information for the day. Open opportunity for anyone to ask any questions you may have right now, and whether we can answer it today or bring it back to think about to answer, in a future meeting. We're certainly, want to hear from you.
Sorry, this is Jennifer Gary. I'm the program manager for the Division of Licensing and Certification. And I would like to add my name to that so that Heather doesn't have to take all of those application questions, because I typically am the one that takes all of those. She's so busy.
Sounds good. Jennifer, why don't you put your contact information right down in the chat for folks?
Where is the chat? That was, I typically do this on Teams. So where's the chat on Zoom? I'm sorry.
It should be a selection down towards the bottom of your screen. I think there's a number of different things you can open up.
Got it. Thanks.
And to in potentially making the slide deck available, I can add your information on there too before we post it up.
I'm happy for you to also take emails from me, Jen, if you're making offers currently.
Yes, absolutely. Oh, I'm sorry. Absolutely. Sorry, that keeps clicking on me. Any change in capacity or applications, any of those questions can certainly come to me.
And Jennifer, I'm curious if someone knows that they're expanding, is there any expectations for, when they should get in touch with you versus when they plan to expand? So is there a too early for a provider to get in touch with you about expansion or not?
No, like Heather said, I mean, the construction piece with the fire marshal's office is what could potentially be a hang up for folks. But if folks have any type of questions at all, they know that they're going to be requesting an increase in capacity. The sooner they reach out and have all the information, the better.
Do you have any more questions, Michelle? Just picking on you a little bit. So if
I can try to think of more, but others are welcome to.
I have a question or comment, I guess. I think so. I'm Olivia from Main Care as well, and we have been had some outreach from providers who aren't currently enrolled with Main Care at all. They don't accept Main Care as a payer, but they've been interested in joining Main Care because now there's this opportunity where they have a facility that has more than 16 beds and they're interested in the services. So if you have questions about what does Main Care cover for residential treatment services, what are the limitations on the services, what are the rates, what are the program requirements? I think that Dean, correct me if I'm wrong, but I think Dean's name's on here and he can help navigate some of those questions and share with you the policy language and tell you where that is online. So I think those kind of questions are welcome too if you're new to Main Care and you just want to learn more about what the opportunities are.
Yes, absolutely. Yeah, both myself and Melanie Miller, who's a part of this call, is a policy writer, and Melanie, if you want to put your name and contact info in there too, like we're both in the policy team and absolutely happy to answer any questions that folks may have around what we currently cover and reimbursement and all that kind of stuff.
Absolutely. I'll put my name and info in there as well. Thank you.
Great.
Hi, Dean, I have a question, and I'm probably the only one on this call that does not know the answer to this, so everybody else, please forgive me. The IMD waiver, what is the longevity of that? Does it ever expire when a state gets the waiver? And I just don't know what the longevity is.
Yeah, so it's a 5-year waiver. And so we can look at requesting extensions, generally. So 1115 waivers are term limited. And so this particular one is 5 years. Now, whether or not it actually ends in 5 years, or if we can look to an extension, that's something we'll have to, look at a little bit for when we get a little bit closer. But
thank you.
Yeah.
Thank you.
Dean or anyone else on the Main Care side, I thought that was an excellent question, Deborah. So, and I bet that you're not the only person who had that question. So thanks for asking it. Do we know of states that have gone past the 5? I don't know if it's been 5 years yet, actually. Even though I reviewed this last night, I don't remember what date this went into effect. So has it been 5 years yet? Has anybody gotten to that mark?
I don't believe so. I think the opportunity became available in 2017. So we'll be looking at that, to be able to answer that question probably within the next year or so.
Thanks for doing that math for me, Dean.
But
no problem.
I will say though, because I think, especially when you're talking about whether to decide to expand capacity or not, like you want to do that for the long term. And while we can't say for certain anything about CMS's stance on this 4 years from now, or however long, we, for example, in Maine have an 1115 waiver that's been in place for almost 20 years, I want to say. I don't know when that waiver started. And then many states have their waivers approved for 10-year periods of time once they've been established. So there's absolutely precedent that 1115 waivers are renewed for more than 5 years. That's common. This particularly, as you saw from the map, there are many states who are taking advantage of this. So there would be a lot of pressure, I think, to continue the opportunity versus just ending it after a 5-year period opportunity. But we cannot say that for certain because we're not the federal government.
Thank you for that. That's exactly what I was thinking, when you consider the different investments in expanding, weighing that out. Thank you. I appreciate all of your answers.
You're welcome. Any other questions? Hearing none, folks feel free to, like I said, reach out to any of us here on the slide or anyone who's put their contact information into their chat. Thank you, Amanda Lee, for putting your contact information in for our provider relations team. So she works directly with providers within our residential SUD programs to kind of answer all these different types of questions around programming and enrollment and give you any kind of support you would need there. So thanks for putting your information out there. And we're we're continuing to work through this process. We'll certainly have more updates to come into the future. So certainly keep your eyes out for new information to come. But we are really excited about this opportunity and really eager to get it going, and are hopeful that CMS will give us the go ahead and very, very soon.
And Dean, I'll just put a plug out there that there's a lot of activity these days going on around budget, and in the not too distant future, I think the governor will be coming out with budget initiatives that are coming up. So everybody should pay attention, and look forward to talking with you again.
Well, thank you very much. Thank you, Michelle. Thank you, Gordon, and everyone else who's been on the call, Dr. Pollard, all the state staff, and all of you who have been able to join with us and listen in today. We really appreciate all the work that you're doing, and are looking forward to continuing to kind of grow with you and, you know, sort of through this process. So thanks so much, and, you know, don't be shy and afraid to reach out if you have any questions. Have a wonderful rest of the day.